Thank you, Navneet. Thank you. Very good evening, everybody, and very warm welcome to the webinar. Today, the session is case presentation by Dr. Radhika. She's the third year GNB pediatric cardiology candidate from Hyderabad Star Hospital. And the panelists are Dr. Saurabh Gupta. Saurabh is in All India Institute of Medical Sciences, Delhi. And Dr. Neeraj Agrawal, he's in Gangaram Hospital. Both are very senior pediatric cardiologists and doing great in their area. So, and I request you all just be interactive. Keep on writing your queries, whatever you are thinking. So make this session more interactive because this is the only platform you can interact with all the faculty all over India. And that is the only purpose of the NB for your benefit, to get maximum from these people. Otherwise, you can't get Saurabh or Neeraj to discuss the case. So, Radhika, you can start your case presentation.
Good afternoon, everyone. Today, I am presenting a case of a patient named Kirtana, who is 10 years old, female patient, resident of Mehboob Nagar, and the informant for the history is the patient herself and the mother. She presented with chief complaints of shortness of breath since 1 year. The patient was apparently all right 1 year back when she started with shortness of breath, which was initially only while playing with the siblings. That corresponded to NYHA class 3, functional class 3, and shortness of breath, it gradually progressed over a period of 1 year, and now it is occurring even at doing routine activities and daily activities. For the past 2 months, that is, it increased from functional class NYHA class 3 to NYHA class 2. This shortness of breath is associated with cough, which was also progressive, and it was more on exertion, non-productive cough, which is aggravated on lying down position, but there is no diurnal or seasonal variation of this cough, and no relation with any food intake, and no relief with any bronchodilators. And also there is history of orthopnea and PND for the past 2 months. There is no history of associated chest pain, any history of syncope, any history of palpitations, no history of any seizures or neurological deficit, no history of any hemoptysis or dysphagia, no history of any failure symptoms, right heart failure symptoms like edema, abdominal distension or puffiness, no history of any bluish discoloration in the childhood, or any history of any sweating episodes, no history of any prolonged fever or any visual disturbances. So the history itself is only for the past 1 year of the shortness of breath. And for these complaints, the child was taken to a local hospital where she was diagnosed with some heart condition about 6 months back, and was referred to higher center for evaluation and management. So the patient came to our hospital and where evaluation was done and 2D echo was also done. And
Radhika.
Yes, sir.
I think we can wait and discuss the history. You can go to the second slide. Do you want to read it again? I think there is some misinterpretation and misunderstanding in your severity assessment. So do you want to see it again?
Sir, the history dated for the past 1 year started with this exertional breathlessness. Only she noticed that while she was playing with the other siblings and other children of her age group, she was not able to catch up with them. And this shortness of, but she was able to do her regular activities, that she was attending school regularly and doing her daily routine activities.
No. My objection is to NYHA class 3.
Okay.
So, I mean, what do you think? How many classes of NYHA are there?
Sir, 4 class NYHA.
4 classes. Okay. Which one is more severe? Which one is less severe?
Sir, NYHA class.
Sickest class is what class?
NYHA class 4, sir.
Class 4. Okay. So here you are saying patient started with 3 and then progressed to 2.
Yes, sir.
So you mean to say the patient improved or patient worsened? Because your description says worsened.
Yes, sir.
Your class says improved.
Sir, class 1 is that there is no limitation of activity. Class 2 is there is limitation of activity.
No, that's okay. But your understanding wise, is patient worsened over the course of illness or improved?
The worsened over the
Worsened. So class 3 is worse or class 2 is worse?
Yes, sir. Sorry, sir. Yes, sir. Sir, from class 2, it has progressed to now class 3, functioning class 3.
Okay. So, I mean, so we are on the same page. There is some minor misunderstanding. Okay, that's okay. So, what is NYHA?
Sir, New York Heart Association classification, functional
Okay.
classification.
What are the other symptoms other than breathlessness?
Sir, for this angina, sir, then for palpitations, then for angina, palpitations, cough, dyspnea.
Just think, just take time and then, okay? The 4 typical symptoms, 4 things are
4 cardinal symptoms, which are cardinal cardiac symptoms.
Syncope, angina,
No, Radhika, see, 3 you have told and we did not interrupt you, which means they are right. So, dyspnea, we agreed. Angina and palpitation are also okay. Now we have to search for the 4th one. Which is the 4th one?
The syncope.
Okay, but syncope usually is either exertional or non-exertional. So it's very difficult to classify it. So it's not a good idea to keep syncope in that class. What else? Cough. Again, how do you grade the severity of cough? Because it can be at rest also. So that also is not a good thing. So what is the 4th one?
one is NYHA is for cardiac.
Yes, sir.
Okay, so cough can be cardiac, non-cardiac. So you can't keep in cardiac symptom. It's not typical for the cardiac. So very beautifully, those 4 cardinal symptoms where it is mainly because of heart. Okay, though there are other causes, but because of heart, then these are kept to avoid the confusion. So 3 you have told.
Angina.
Yeah, angina, palpitation, dyspnea ho gaya. Then 4th one? Fatigue.
Fatigue, yes.
Okay. So what is the prerequisite when you can use NYHA class? Somebody can come with dyspnea and if you examine, you did echo. Echo is normal. Everything is normal. Can you use NYHA classification for that dyspnea?
Sir, for this NYHA classification, basically we use for the cardiac symptoms when we
Yes.
realize
So
that
having cardiac disease is the prerequisite for NYHA classification. But here we are taking a priori assumption that we are likely dealing with a cardiac disease. So we are using it NYHA. Okay. So any other classification system you are aware of?
So WHO classification for pH we had, sir.
Okay.
Yes,
Any
sir.
other?
Then Canadian classification score.
Okay.
So it is cardiovascular scoring system. Then, sir,
For pediatric, for younger kids?
then IHT
This child is 10 years, so we don't mind you using NYHA classification.
Ross classification. Sir, Ross classification. Yes, sir.
So at what age you can start using NYHA? Below which age NYHA is not a good classification?
So less than 6 years.
Less than 6 years. So you understand all that. Okay. So in terms of when a patient has orthopnea PND,
yes, sir.
What do you understand by that?
Sir, that will because orthopnea PND means the class that the functional classification is more, maybe it is class 4, NYHA class 4.
But then your history says class 2. So which one are you committing to?
Sir, initially it was class 2, but now for the past 2 months, according to history, now it has become class 4. That is with orthopnea and PND for the past 2 months.
Okay. So in terms of hemodynamic, dyspnea is equivalent to what? You understood the question?
No,
so
sir.
if you have dyspnea in a patient, what it is implying to you in terms of cardiac hemodynamic changes?
In this cardiac output, he is not able to maintain cardiac output.
That's
and
not true.
Radhika, think and then answer.
Think. So when cardiac
Dyspnea
output
and
is low,
fatigue, these
it
two are
is usually
different.
fatigue. Okay. And we have a different set of etiologies like AS. Okay. So dyspnea is not equivalent to cardiac output. So what it is related to? Okay, what disease comes to your mind if somebody comes with dyspnea? Tell
Sir,
3-4 diseases.
Yes, sir. There can be valvular pathologies, cardiac diseases.
Like?
It can be valvular pathologies like obstructive lesions, left-sided obstructive lesions like aortic stenosis or mitral stenosis, or left atrial myxomas or obstructive lesions, sir, of the left
So what is common to all of that in terms of hemodynamic abnormality? What is common to all of that?
pulmonary venous congestion.
So pulmonary venous hypertension. So one of the major causes of cardiac dyspnea is pulmonary venous hypertension. There can be other causes, like for example in tetralogy. Do they have dyspnea?
Yes, sir, they can have, sir, dyspnea.
Okay, but there is no PVH in TOF. So then why there is dyspnea?
Sir, in that it is not because of the hypertension, but it's because they have the relative hypoxia, and that relative hypoxia, it will cause the ventilation perfusion mismatch, which is causing dyspnea on exertion.
Yeah, it's partly correct. You should say that there is desaturation, which further aggravates during exercise. So that further decrease in oxygen saturation is perceived as dyspnea. So the mechanisms are different. Okay, one is PVH. There can be J receptor activation, other things, and then
yes.
Okay, why some of the right-sided diseases? Do you think ASD has dyspnea?
Yes, sir. They can also have exertion. They also have exertional dyspnea, sir. ASD.
So why is that? Why?
They have hyperkinetic pH and.
But PVH is not there.
PVH is not. Yes, sir.
Then why there is dyspnea in ASD? I mean, these are some of the typical questions which will be asked. What are the causes of dyspnea in right-sided lesions, or the prototype of which is ASD?
Yes, sir.
So why? Okay, PAH. Does PAH have dyspnea?
On exertion, sir, they can have PH.
So what is the mechanism there? Because PVH is not there in them also.
So because
already dyspnea has multifactorial
yes.
Causation.
Yes.
And you should be knowing all of that. Some of the people are answering in the chat box, and you should be reading that. Why it is important is because dyspnea is a very non-specific cardiac symptom, and then you cannot pinpoint etiological diagnosis. It can happen in so many diseases. That's why it is important to understand dyspnea and its causation in different diseases. Dr. Neeraj, if you have any questions.
No, sir. Actually, I was trying to ask for the next slide. Can you go to the next slide? About next slide. Radhika, can you go to the next slide? In the negative history.
Yes, sir.
Are you not talking about shunt lesion here at all? You have not discussed about the shunt lesion and the PH Alzheimer's physiology. Suppose a child has recurrent chest, you not asked about the history of recurrent chest infection in a cardiac case, pediatric cardiac case. Are you sure this is not a left right shunt at all? Dr. Saurabh just now explained detailed about the, especially about the ASD.
Yes. Sir, I asked about recurrent LRTIs or failure to thrive, but the history is only for the past 1 year, and there were no, before that, the child was completely asymptomatic. There were, according to parents, there was no recurrent LRTIs, there was no history of failure to thrive or a poor weight gain throughout the childhood, and the child was apparently all right till 9 years of age.
So what are the lesions which can present with dyspnea, left or right shunts in the beginning without being asymptomatic and suddenly they present 10 years of life? Is it possible to have a shunt lesion presenting directly 10 years of life? Is it possible?
Sir, yes, sir, it can be possible, sir. If there can be two possibilities. First, if the shunt lesions are large enough that they were initially causing the symptoms, that is recurrent LRTIs in the initial years of life with failure to thrive, but then they go into they develop irreversible PH. In between, the parents will perceive that the child is doing well, and the symptoms will disappear. Like there will be no further episodes of recurrent LRTIs or poor weight gain. And then again, the child, when there will be irreversible PVR, the child will start having the symptom.
Understood. Your case is not like this. No, your case is not like this. There's no history of, just told us, there's no history of recurrent chest infections. So we're trying to find out, this child has been asymptomatic for 9 years, presents with dyspnea. Do you still think of a shunt lesion?
Yes,
No.
yes, sir. There can be like VSD, which has now called RCC prolapse, leading to aortic regurgitation. Maybe the VSD was small, not causing any symptoms, and was not noticed in the childhood. And now, because it has developed the aortic regurgitation and the child has become symptomatic, it can also occur, sir.
So if the child is at AR, when the child will present this, at what stage?
At what age, sir? With
What
VSD,
stage?
yeah.
What stage of?
Usually, sir, they present around 5 to 8 years of age, sir, with this VSD with aortic
But
regurgitation.
the AR has to be severe, no? AR has to be severe and causing LV
Dysfunction.
only then. So it's a late phenomenon, not early, but it's possible. Yes. And either is more common than this. So why don't we talk about large ASD shunt?
VSDs.
Is it possible to have ASD at this age, 10 years? Is it
Yes,
possible?
sir. Yes, sir. It is possible, sir. That
What is the
ASD.
commonest age? What is the commonest age for ASD?
So ASDs usually they present around when this after 2 years of age. So they can present if there is a large ASD.
Other presentation, one is early presentation, which is uncommon. Most common presentation is investigate.
Yes, sir. In the early childhood, like sir, 5 to 8
No,
years.
third decade. Normally, if you're talking about dyspnea and ASD, mostly third decade or recurrence in first few years of life. Okay, so because dyspnea is the culprit here, you cannot rule out the shunt.
Yes.
So even the large VSD patients, they may remain asymptomatic for 5-6 years. They will present this right now because of non-regulation of the pH. That also has to be kept in when you're taking the history, and you can't rule out the shunt. Okay.
So, Radhika, I'll just come in here. See, you discussed, Dr. Neera suggested that it can be shunt. How likely is the shunt? It is likely or it is less likely?
Well, it is less likely, sir, the shunt lesions.
Why?
Sir, if the shunt lesions were large shunt lesions, there should be have a definite history of recurrent LRTIs or any
other thing. Any other thing which makes it less likely in your patient?
And if they have developed irreversible PVR or they have Eisenmenger, this is the very early age that
more important than that is the progression of disease. You see, 3 months of disease, and you are almost trying to say that the patient is class 4.
Yes.
See, the class 4 is not something which happens in any shunt lesion.
Yes.
On which conditions shunt lesion can have class 4 symptoms?
So like VSD with severe aortic regurgitation.
It has to be acute AR, no? How many times acute AR will happen in VSD? Very, very unlikely. It can happen only if there is infective endocarditis.
Yes, sir.
Or something like that.
Or anemia.
So this tempo of illness, which is like relatively rapidly progressing, what will come to your mind? Dyspnea, as we discussed, can be because of shunt lesions, can be because of valve lesion, it can be myocardial disease. So that's how you will put your sequence of differentials.
Yes.
So, I mean, in which conditions you will think that this progression will fit in?
Sir, it is fitting more into left-sided obstructive lesions like aortic stenosis or mitral stenosis.
Mm-hmm.
And
you will keep the DD of acquired thing?
Yes,
even
sir.
if you have not
Yes,
negative
sir.
history, you are not.
Yes, in myocarditis, maybe they have only 1 year history. It is not
1 year history or other thing in India is 10 years. His congenital acquired and everything you need to keep. He's 10 years. He's at that age.
Kawasaki disease, it can be. but very
Yeah,
late.
the most
5 years,
common
usually they present very early, up to 5 years.
Okay, you tell in the list of, you list out the diseases in their commonality. One is congenital heart disease. Number two,
Uh,
which is the most common acquired heart disease in a child.
rheumatic heart disease.
So the rheumatic, when you are saying valvular, again you have to think.
Yes, sir.
Okay. Then comes other infections.
Yes, sir.
Okay.
Cardiomyopathies or myocarditis.
Mhm.
So negative history has to have joint pain, has to have
Yes.
it's not there in the list. It has to be not complete.
Yes, sir. In the past history, sir, I asked about that. There was a history, sir.
Okay, I think we can move ahead, Dr. Neeraj, Dr.
Yes,
Bhunesh, ma'am.
yes, sure, sir.
Yep.
So for these complaints, the child was taken to a hospital where she was diagnosed with some heart disease, and she was put on some oral and injectable medications also. And she was advised to take these oral medications regularly and these injectable medications every 3 weeks. And since then, the child is on continuous follow-up. And symptomatically, they are saying with the past 1 month, once they have started these medications, 15 days, she is little better. In the past history, there is a history of fever 2 years back, and but which remained for about 1 week. But for that, they take only oral medications. But they were saying that they was not associated with any severe joint pains or any edema or any abdominal distension at that time, and the child was not even hospitalized for that illness. And at that time also there was no history of any drug intake, and she was not advised to start any long-term injectable medication or oral medications. So only the history was only fever was 2 years back, but only for 5 days it remained.
Okay.
It can
So-
be any.
So you are thinking that it's not very significant febrile illness.
Sir, it could be sir, significant. That's why I specifically asked about the
Okay.
joint pains, because we were thinking on the terms of acquired.
So you are not thinking of rheumatic fever. What kind of fever you think is this, which can have significance for a cardiac disease?
Sir, initially I was thinking on the lines of rheumatic fever also. That's why I specifically asked for the joint pains in that illness and whether she was hospitalized or took any NSAIDs for the relief. But there was no history of any joint pains at that with that episode of febrile illness.
Okay. Since you are discussing rheumatic, so what is the cutoff of fever for rheumatic fever versus infective endocarditis? You understood the question?
Yes, sir.
Ah.
Yes. Sir, for rheumatic fever only, sir, with the revised Jones criteria, which were now given in 2050, we divided into two groups depending on the annual incidence of rheumatic fever. If it is less than 2 per 1,000 of school children, they were classified in low risk population, where the
2
criteria
per 1,000 what?
of
Prevalence, incidence
incidence in school age children of
what?
Of rheumatic fever in school age children, or less than equal to 1 per 1,000 of population of any age group, but less than 2 in school age children.
You should read that because that is very important. Okay, so there are two types. One is low prevalence, one is high prevalence. So is there a difference in high and low prevalence in terms of fever cutoff?
Yes, sir. There is a difference in fever in both the criteria, major and minor criteria. In major criteria, even the monoarthritis and polyarthralgia is taken as a major criteria in high risk population, where incidence is more than 2 per 1,000 school age children. And whereas in low risk population, it has to be polyarthritis is taken as the major criteria. And also in minor criteria, the fever cutoff is and ESR values are different. In fever, it is more than 36.5 degree Celsius in places with low risk population, and
Not 36.5. No, 36.5 is what? That is normal, less than normal. 38.5 and 38.
38.5 and 38 in 38 in high risk population.
Okay.
And
So I
6.8.
think all of those who are listening, some of you are writing. So all of you should know different criteria in different population groups. The question is why these are two different criteria? What is the need of having these two different criteria?
So that we can pick up the disease early, and because
You keep only one. Why confuse? Why bring so many questions unnecessarily?
where the incidence is more, they have seen that even those with subclinical carditis is also seen in those patients, and the complications later are more.
I mean, that is only partly true. The bottom and the main reason is that in areas with high prevalence, you want to pick them more, so more sensitive. In areas where it is less likely, you want to be more specific so that you don't overtreat. Here in India, it's better to overdiagnose because you can treat them and prevent the long-term RHD and other complications. In countries like Europe, US, where it is very less common, they should be under-treating. I mean, it should be very specific criteria. That is why these are two different ones.
And what is the prevalence? Like this is 1 per 1,000 is the prevalence in general population. You know what is the prevalence in India? There was an article from AIMS, field study on. You should know because why India is kept in high risk group. This is 1.8 to 11, average 6. So you can imagine what number we are dealing. And because we are mostly being missed, that's why this to capture more patients with these criteria things are being planned. So you can imagine 11, 1.8 in one extreme and 11 in other extreme. So this is wide range we have, and huge number of rheumatic patients are there in India. We are hardly getting actually anything to our centers.
Okay, we can go ahead.
So coming to birth history, she was born out of a non-consanguineous marriage with birth order first, and with full-term normal vaginal delivery with a birth weight of 2.5 kg, and cried immediately after birth with no history of any NICU stay, and there was no significant antenatal history. Mother was fully immunized during the pregnancy with 2 doses of tetanus toxoid. There was no history of any hypothyroidism or gestational diabetes, and no history of any drug intake or radiation exposure during the antenatal period. Then the development history, as per the mother, she achieved her milestones as per age, and presently she is studying in class 4th, and she is an average school performer. And in immunization history, immunization was done as per national immunization schedule up to 5 years of age. In personal history, she is a vegetarian with normal sleep pattern with regular bladder and bowel habits. And there is no significant similar history of family history of such complaints, or any sudden infant death in family, or any family history of congenital heart disease. According to socioeconomic history, they belong to lower middle class according to modified Kupusomi scale. So I summarize my history saying that 10 years old female who presented with a history of shortness of breath for past 1 year, which progressed from NYHA class 2 to NYHA class 3, class 4 with associated with PND orthopnea. And so my differentials according to history, it included both congenital, it could be congenital heart disease also, or acquired heart disease also, but the history is very short. For the past 1 month with 1 year with dyspnea. So first will be the any acquired heart disease like recurrence of rheumatic fever, or juvenile mitral stenosis, or it can be other lesions like myocarditis, or any cardiomyopathies, or it can be mitral valve prolapse, or shunt lesions like VSD with AR.
So,
Or
okay, we can see the list. Which one do you want to take off from the list? Which one to take out, which are probably not relevant here? As we discussed, VSDAR, do you think that this is likely?
So very less likely, sir.
Okay. How about RSOV?
Sir, also there will be very acute history and not be lasting for the past 1 year, like this year.
No, what more do you want to make it RSOV? What is missing here? What is a common form of RSOV?
This ruptured sinus of Valsalva into either into RA or RV can occur, so they can present acutely with the right-sided failure symptoms.
So right-sided failure is not there.
Yes.
So sizable RSOV towards the right side is less likely. A small RSOV still may be there, but
yes.
Then the patient won't be symptomatic.
Yes.
So I think VSDR and RSOV becomes quite less likely here. When you talk about ventricular dysfunction, I think that's what you have in your mind?
Yes, sir.
One of the differentials. What is other causes of ventricular dysfunction?
It is cardiomyopathies or myocarditis,
Okay.
but there is no history of associated chest pain or syncopal.
Any other?
Or in COVID.
So COVID you have to bring in current circumstances, you have to bring in MISC and its consequences and other things.
Yes, sir.
Then what about aortoarteritis?
Yes, sir.
That has to come in.
Yes, sir.
Why are you talking about recurrence of rheumatic fever? Why not say primary first? Talking about rheumatic heart disease?
Yes, sir.
Or rheumatic fever?
Sir,
so do you think yes? Go on.
Okay, what is mimetic illness?
Sir,
in terms of rheumatic fever?
Sir, in rheumatic fever, it will there won't be classical history of fever with joint pains.
Okay, I'll ask you in a different manner. If a child had fever, rheumatic fever at 5 years of age with arthritis,
yes,
there is no carditis, and the child again had another episode of rheumatic fever at 8 years of age,
yes,
what is the likely presentation? Is it more likely to have carditis? It is less likely to have carditis, or it does not relate to the first episode?
Sir, usually this arthritis is inversely proportional to carditis.
That is okay. That is okay. I have given you a scenario
yes,
where child had arthritis.
Yes.
Now second episode. So
recurrence of rheumatic fever can occur, sir, if again he had fever with.
That is true, but which is likely to be the manifestation, arthritis or carditis?
Carditis, sir.
No. So mimetic. So it mimics the first episode. So if the child has had arthritis in the first episode, it is more likely to be non-carditis rheumatic fever with arthritis. If carditis is the first episode manifestation, then the child is likely to have carditis again. Okay. Fair enough. I think any more questions, Dr. Neeraj? We can go to examination. Yeah, we can go to examination.
So coming to head-to-toe examination, the patient was conscious, cooperative oriented and comfortably sitting in bed at the time of examination. He was lean built with no obvious facial dysmorphism. There was no pallor, icterus, edema or lymphadenopathy. There was no clubbing, no visible or palpable thyroid swelling. There was no apparent cyanosis at rest, or even I made her to walk for 6 minutes. There was no cyanosis. There was no limb discrepancies or no musculoskeletal abnormalities. There were no neurocutaneous markers or no signs of any infective endocarditis. This jugular venous pressure, JVP, it was mildly elevated. It was 4 centimeters above sternal angle with normal respiratory variation with prominent A waves and positive hepatojugular reflex.
So what do you mean by positive hepatojugular reflex?
Sir, this when I was examining her and she was in, sorry, sir, just maybe. I was examining for the JVP and I made her to sit so that I could not see the this elevation of JVP.
No,
So I made
it
her
is
to
positive hepatojugular reflex.
yes. When we compress the abdomen for about 15 to 30 seconds, so there in normal individuals where there is no increase in the right atrial pressure, so there will be only transient increase in the JVP, which will subside in less than 10 seconds. But
Okay.
if there is sustained increase in the jugular venous
Can you go to that slide which says hepatojugular reflex? Okay. Is it reflex or is it reflux?
hepatojugular reflux.
So it is not reflex. For reflex, you have to have what? Efferent, afferent, and action.
Yes, sir.
Here it is a passive transmission of pressure onto that. Okay, go ahead.
Coming to vitals, pulse rate of 102 per minute with regular in rhythm, normal in character, good volume pulses with no radial or radiofemoral delay. All peripheral pulses were well felt with a respiratory rate of 16 per minute. And BP was 100 by 68 millimeters of mercury in right upper limb and 104 by 70 millimeters of mercury in right lower limb. Temperature was 98.1 degree Fahrenheit with a 4 limb saturation of 96 to 98% in all 4 limbs. Her anthropometric measurements, weight was 22 kg, which was between 3rd to 10th centile of IAP growth charts, and height was 126 centimeters, which was also between 3rd to 10th centile of IAP growth charts, with the arm span of 125 centimeters and head circumference of 53 centimeters and BMI corresponding to 13.84 kg per meter square, which was between 10 to 25th centile. And she was in Tanner stage 1 of pubertal growth.
Okay, go on.
Then coming to cardiovascular examination, on inspection and palpation, trachea was central with no scar marks or musculoskeletal abnormalities or any
Dr.
dilated.
Radhika, I think we have a lot of ground to cover. So you just tell the positive findings and move ahead.
Okay, sir. Sir, the apex beat was apex was localized LV type of apex with the retractions medial to the apex, and it was in 5th intercostal space. There was grade 2 left parasternal heave is present, and with palpable second heart sound in second left intercostal space, and diastolic thrill was also present at apex on inspection and palpation.
Okay.
Percussion was, sir, there were no significant findings except that the left second intercostal space was dull. On auscultation, there was first heart sound was single and loud, and second heart sound, there was loud P2 component of second heart sound. And on coming to murmurs, there was two murmurs, distinct murmurs. One was mid diastolic murmur, which was low pitched, rough rumbling in character, which was and longer in duration, and it was best heard with the bell of the stethoscope in the left lateral position in expiration. And there was also pre-systolic accentuation of this diastolic murmur. And in addition to this, also there was grade 3 pansystolic murmur, which was high frequency, and it was along the left sternal border in 3rd and 4th intercostal space, and it was a non-radiating murmur. Also, there was no additional S3 or S4, but there was opening snap was present with a narrow opening snap S2 and OS interval. On other
Nothing-
system examination,
Nothing significant here.
only in per abdomen, sir, the liver was 2 centimeters below right coastal margin. Rest was normal, sir. On respiratory, there were no additional sounds.
Okay.
So, yes, sir.
Do you have a final diagnosis slide?
Sir, after history and examination, my
Okay.
final diagnosis will be most likely it's a acquired heart disease, most likely rheumatic heart disease with severe mitral stenosis, with severe pulmonary hypertension, with resting tachycardia and no signs of any heart failure or infective endocarditis with functional class 4, NYHA class 4, sir.
Okay. So what is missing in this? So first of all, after valvular lesion, there has to be a mention of pulmonary venous pressure.
Yes.
Then only you can talk about pulmonary hypertension.
Okay, sir.
Then second thing, I think you had a pansystolic murmur which you wanted to talk as TR.
Yes.
It is missing in your diagnosis. That's what you meant, or you meant something else?
So because of pulmonary hypertension also, I think child was having tricuspid regurgitation and that murmur.
So TR is part of the diagnosis.
Yes.
No, that is not featuring in here. That's what I am saying. So you should write what degree of TR, mild, moderate, severe.
Sir, it's a moderate degree of TR because there is a pansystolic murmur, but there is no right heart failure symptoms or edema.
And ventricular function you have
Ventricular
to talk.
function is good. There is no right ventricular S3 or S4, so and no failure symptoms, so no heart failure.
So basically you are saying RHD, severe MS, PVH. What degree of PVH? What degree of PAH?
Severe pH and moderate to severe pH and moderate to severe pulmonary venous hypertension also. So.
When you say class 4, you cannot say moderate. It has to be severe.
Yes.
We are just trying to tell you that everything has to be consistent with each other. Right? So now the question is, if there is TR, what JVP do you expect?
So there should be, in addition to JVP is only mildly elevated in this case, so maybe it's more elevated with prominent V waves in TR.
So why your V wave is not prominent? Why you are getting A wave?
Because of the pH in.
So pH changes the waveform. So I think there is error in that. Okay. So you have to be careful when you say your JVP.
And this chronic word in RSD, rheumatic heart disease, rheumatic fever, rheumatic heart disease, these are the two things. No?
Ma'am, presently there is no fever and also there is a
The fever means rheumatic fever. Fever means rheumatic fever. Rheumatic heart disease doesn't have fever.
Yes, sir.
It's
So you should say RHD with no active rheumatic fever or activity. Go back to your cardiovascular examination. That murmurs.
Yes, sir.
Okay. Now, you see this grade 3 pansystolic high frequency murmur. I mean, do you think it is a high frequency murmur? What murmurs are typically high frequency murmurs?
So regurgitant murmurs like
AR murmur, no?
AR
So is this murmur like a AR murmur?
as compared to mid diastolic murmur, the frequency was high when I compared. So
high and low, there is something like mid and mixed frequency murmur. So usually high frequency murmur is only AR murmur and hypertensive PR murmur. Okay. In current times, possibly we are having less significance on interpreting these, but at least you should understand why this is mixed frequency and why AR murmur is high frequency murmur. Okay. Why are you keeping? There is no differential. You are having only rheumatic heart disease.
Sir, at the end of history, there were
Okay. What if I say this is congenital MS?
a very late presentation and only for the past 1 year. Maybe it can also occur with.
Yeah. So it is there. So what in examination? How do you differentiate congenital MS from rheumatic heart disease MS? What are the differentiating findings?
This opening snap, pre-systolic accentuation.
Yes. So opening snap won't be heard. Pre-systolic accentuation won't be there. Okay. I think rest is fine. What was the heart rate you said?
Sir, 102 at the time of examination.
100?
102. 102.
So is that tachycardia?
For the age of 10 years, sir, it is in resting tachycardia, sir.
When do you diagnose tachycardia? At what heart rate? I think 100 is the cutoff. So what is the cause of loud S1?
Loud S1 because of the rheumatic heart disease, because of the mitral stenosis, there is increased left atrial pressures, and when there is after this in isovolumetric contraction, when both the valves are closed, so because the valves are thickened in rheumatic heart disease, so that will produce a loud single S1, sir.
It also signifies the mobile mitral
Pliability of the valve.
Pliability of the valve. Any questions, Dr. Neeraj?
Yeah, actually, I'm trying to find out how did you interpret loud B2? Why is not loud A2? How did you interpret? How do you know this is loud B2, not loud A2?
Yes, sir. Sir, it could be both, but because it is palpable and all the other clinical findings that are more in favor of this, it is looking more like a mitral stenosis, which is associated with pulmonary hypertension, and also there are prominent A waves. There is parasternal heave associated. So, sir, it's more likely loud P2, and it's localized to the second left intercostal space.
Yeah, but don't you think A2 can be heard in second left space? What are the conditions when you hear the loud A2 in second intercostal space?
Yes,
What are the
pardon, sir.
conditions? When do you hear the loud A2?
Yes, sir.
Loud A2.
Yes, sir.
In what conditions? In what conditions do you hear loud A2?
Yes, sir. Sir, if there is any causes which cause which results in the increased hangout interval across the semilunar valves, either across the aortic valve or the pulmonary valve, it can, or there is a increased flow across the valve, like in hyperkinetic PH in shunt lesions, it can cause loud P2. Or if there is a stenosis, not stenosis, increased flow across the valve or increased hangout interval across the semilunar valves, or if there is a.
So, it's anecdotal. You are trying to imply that loud P2 can be anything, but yes, you are right. Looking at the whole scenario, but probably examination you say loud P2.
Yes.
Most of the people, because you can't differentiate it. You can't say that. That's
yes.
So you can say loud P2. Most likely, maybe not because of seeing the other end. Okay.
So, Radhika, how do you assess the severity of PAH clinically?
Clinically, sir, on this cardiovascular examination, or?
Yeah, cardiovascular examination.
Sir, in this, depending on the JVP or in inspection and palpation, heave, if there are and presence of this palpable P2, whether it's there or not, sir, that is.
So
and comparing the loudness of P2.
Is it something to do with the area over which P2 is heard?
Yes, sir. Yes, sir. Comparing the loudness of P2, and usually it is it is confined to the second left intercostal space. But if in cases of severe PH, it can be even heard all over and even at the apex.
Yeah, I asked this because sometime back, few sentences back, you said the opposite. So P2, if it is heard beyond second space, it may also indicate PAH. Number two, what are the exceptions to this understanding? In PAH assessment based on P2, what are the exceptions to this?
If there is a single only.
In which condition, even if you are hearing P2 at apex, it may not indicate PAH. You got the question?
Yes, sir.
Okay. ASD.
Okay.
Okay. The RV forms the apex. Whenever RV will form the apex, P2 may be heard there, but it may not be indicating PAH. Okay. We can go to investigations.
First, coming to chest X-ray. So this is chest X-ray PA view with a well-exposed film, well-centralized, well-exposed film with a normal abdominal situs with a gastric gas, this stomach gas bubble seen on the left side, and normal bony cartilage, and there is a CT ratio of 0.60 with a LV type of apex with there is a prominent this LA appendage on the left side, and this dilated pulmonary artery is seen on the more on the right side, and also there is this pulmonary vascularity is more on the upper zone, so there is like redistribution of flow or capitalization of vessels, which is seen in pulmonary venous hypertension. And
what about pulmonary comas?
Strum, sir, uplifting of this left bronchus is also seen, but carinal angle is not that wide. But
so the conus
is definitely wide. Means if you look, it is definitely wide.
75. Okay.
So this is more than that. It is almost 90 degrees.
More than
Dr. Neeraj is asking about the pulmonary conus. Its main pulmonary artery segment.
Yes, sir. That is dilated, sir. More.
Main means on the left. Come to left. Bring your arrow to left. Yes.
This part.
It is. I'm not sure. This is LA appendage is overlying or
no, LA doesn't go that up. Okay. LA has its LA appendage has its. So you should know the left boundary of the heart.
Yes, ma'am. So both left and right.
Go the cursor up. Slightly go the cursor up.
Yes.
Yeah. You can see the corneal tissue. Yeah. This is the prominent corneal tissue. Then adenoids. Not go so high. Where is the LPA here? The LPA, your side RPA is prominent. You can't see the LPA here. Where do you see the LPA? Left pulmonary artery on X-ray.
Yes, sir. Here only, sir.
It is retrocardiac in view, but
yes, sir. It won't MPA. Yes,
still followed. It is prominent area.
Because I think penetration, the X-ray film means it is over penetrated. So commenting on pulmonary venous hypertension become very difficult with this film. You can see whole of the spine through and through. So over penetrated film has its own limitation when you need to comment on the pulmonary vasculature.
But ma'am, as compared to lower zones like
cephalization is there, but things are underestimated. It could be more.
Type of apex you think this is what type of apex? How do you define the type of X-ray?
Sir, pardon, type of apex?
Apex in X-ray, how do you define?
Yes, sir. Sir, if it is a down and out type of apex, it will be LV type, and RV, because it is anterior, it won't be in the PA view, its enlargement won't be seen. Mostly in the lateral view, we can comment on the RV enlargement, and it will be rounded if there is a RV type of apex.
Are you aware of the cardiophrenic angle the type of effects? Are you aware of the cardiophrenic angle and type of effects?
Yes, sir.
Cardiophrenic angle and
Yes,
type
sir.
of effects. How do you know? What is the definition of cardiac effects based on
Angle. So
cardiophrenic?
depending. Yes, sir. Depending on the cardiophrenic angle.
Define how. This is what angle? Cardiophrenic angle is how acute or obtuse? This is acute angle or obtuse?
This is obtuse, sir.
How much do you think the angle is? Less than 90 or more than 90? Cardiophrenic.
Less than 90 only, sir. It is
So what is
acute
the
angle.
effects type?
Yes.
What is the effects type? Acute type. So what is
Acute
the
angle.
now? Do you want to change the effects type on X-ray?
RB
So
type of.
yes, so X-rays are deceptive in type of effects. If you have clinical findings, you should go with the clinical finding. For an X-ray, this is less likely of finding. This is mostly matching with the RBMs. This is not matching the clinical finding, that I understand. But by definition, this is cardiophrenic angle is less than 90. This is acute angle, and this cannot be called as
Okay.
What else do you expect in this X-ray from your clinical history and examination? You have a diagnosis with you.
Yes, sir.
So what else do you expect?
Sir, two things. First, on LA enlargement, we can have
That we have discussed, no? Whatever you have not discussed, but you expect.
the pulmonary venous hypertension. We can
That
have
also you discussed.
curly lines and
Something you did not discuss, but you should be expecting. RA enlargement, if you have severe TAR.
severity.
So is there RA enlargement here?
No, sir. It is around
How
3.
do you diagnose
Yes.
RA enlargement?
Sir, if it is occupying more than the 5 spaces, this right-sided, if this right cardiac border, RA border is occupying more than the 5 intercostal spaces.
5 is too much. you are expecting too much. Diwali sale is still not on, so you have to do with this only. I think this suggests that RA enlargement. You should know what are the criteria to see in a child and in a grown-up patient. Okay.
Vertically plus horizontally. So two numbers you need to remember, and obviously you need to see.
And in all of this, I think in X-ray we should always say that these are not very specific or sensitive signs. So whatever we are discussing are more likely or less likely. There is nothing like, especially for when Dr. Neeraj said and discussed that in detail. But apex, generally we know that we are not accurate on X-ray. So we need to understand this whenever we say. So if that query comes to you during examination that you are saying something, and examiner is saying something else, then you can always bring in that point that X-ray is not the perfect tool for apex assessment. Okay. Shall we go to the next one?
I go to ECG.
Yes. This is 4-channel 12-lead ECG with the half standardization with the
This is 1/4. Chest is 1/4. Limbs half.
chest is, yes, sir.
2.5.
Chest leads are, yes, sir. Limbs half, that is 5 millimeter per MV, and chest leads are 1/4 standardization with a sinus rhythm with a heart rate of around 100 beats per minute with the P wave axis is normal. With P wave morphology, it is P pulmonale, that is P waves are peaked, and also in V1 there is a negative deflection more than 1 mm. So it is suggestive both of biatrial enlargement. And with the QRS axis of around plus 90. And there are
What is the axis you said? What axis did you say?
Sir, it is in, there is a right axis deviation, but it is around 90 to 100. One is negative and AVF is positive, so there is a right axis deviation. But they are also equiphasic in one, so almost equiphasic in one, so around 90 to 100.
What is sinus rhythm? What is sinus rhythm?
Each P wave is followed by QRS complex.
Is that sinus rhythm? That is AV, 1:1
That
AV
is 1:1
conduction.
conduction.
1:1 AV conduction.
So what is sinus rhythm?
Defined.
Sinus is related to what? It's for SNO. So you
Yes.
see from think that way. What is sinus rhythm?
Heart rate of
No. That is tachy or brady. Sinus relates to P wave origin. So P wave origin will determine whether it is sinus or not. So if it is normal origin, lead 2 will be the tallest, and P wave axis is normal, then it is sinus. According to the situs, right?
And the PR interval has to be normal also. PR interval, what do you think, sir? PR interval has to be normal also to call it.
That's not necessary.
That is AV node area. PR interval means we are talking of AV
That is
node.
related to AV node.
AV
So
node.
sinus means we are looking at the origin of P wave.
Normal P wave morphology with normal axis. Sometimes it is very small, axis is normal, but PA is very small because it is coming. So that is obviously not a sinus. So there is 1:1 conduction.
So RAD, RVH with the atrial abnormality. Is there LA enlargement?
yes, sir. There is in V1. There is only negative component of this P wave. It's
Yeah.
more than the positive reflection, so suggestive of biatrial.
Okay. Can go to echo and see.
We have 5 minutes.
Yeah, that's what.
But Deepika, why did you take ECG in 2.514? Because there was a space. This was not so large complexes that you need to come to one. No?
Yes, sir.
Because here RA, LA enlargement is so important that for that we need to have proper voltage, right? Okay, go ahead.
It's not playing.
Okay, I think you can tell a diagnosis on it.
Yes,
Can-
ma'am.
that's the diagnosis.
Not opening. I'll try
Not
once.
opening, you can tell a diagnosis.
I don't know, ma'am. It's not playing.
Okay, right click can open with.
Is the diagnosis same or different?
Sir, this is, sir, this patient, same, sir. This is a juvenile severe mitral stenosis.
So what is juvenile mitral stenosis? How is it different from routine mitral stenosis?
Yes, sir. Sir, usually they have seen that even after the rheumatic fever or this rheumatic carditis, it takes almost 2 decades to have this to development of mitral stenosis. But in Indian subcontinent, there is a
That is
study.
inherent in juvenile, no? So now why to expand on that? You come to what are the characteristics of juvenile MS?
Sir,
It is already involved in that.
Yes, sir. It is where it will where the mitral stenosis will present very early, and
Okay.
there is a history of rheumatic fever in about 70% of cases, and there is a very early progression to severe mitral stenosis.
Okay.
Even within 3 years, it can even the 70% can progress to severe stenosis, and there will be, but there are, because it presents very, there are the most commonly it is seen in boys as compared to.
Let me ask you straight. What are the differences in terms of PA pressure? What are the differences in terms of AF?
Yes.
What are the differences in terms of LA size?
Yes, sir. Sir, LA size will be less. The LA will not be that enlarged because there is not much time for this because it develops and progresses very rapidly. So
Okay.
there won't be much enlargement of the LA as compared to adults where of chronic rheumatic heart disease. Secondly, atrial fibrillation incidence is very less in juvenile MS as compared to adults with rheumatic heart disease.
Okay.
And but PH, because the severity is it progresses very early, so the severity of PH is more.
Yeah, so you're reasonably right, but you have to make sure that you don't utter these unnecessary adjectives like very less, because that then you will be asked what is the percentage.
Okay.
So you can simply say AF is less common, and that's it. And also, as somebody has also mentioned in the chat box, that calcification is quite uncommon. Subvalvular disease may be much more common. And since the discussion is coming to rheumatic MS, you should read a few papers about PTMC for juvenile MS, how good, whether it is equally good compared to adult PTMC or not. Because if you have a case in exam, that discussion will come. So I think we can, I mean, time is over.
Thank you, Radhika. Good case presentation. And these are the very important tips given by Dr. Saurabh and Dr. Neeraj, which everybody has to learn and get used to for these, because these are the questions being asked in exam. Nothing
Ma'am,
extra.
one question. I'll just interrupt here. Who described juvenile MS?
Sujoy Roy.
Who was Sujoy Roy?
1971, he published the paper on this.
What was his birth nationality?
From India only, sir.
Birth nationality. That is why I asked you. He was from Burma, present-day Rangoon. He as well as Dr. Padmavati, both are from olden days Burma and today's Rangoon. So history is also quite fascinating. I mean, we relate more if we know about the history. So if you people are interested, just go back and read few lines about these two guys. These two people have changed the history of cardiology and say pediatric cardiology in India. So you should know. Sorry to interrupt, ma'am.
Yeah, no, it's good. It's important information. It's better everybody gets that. So I think thank you everybody. Everybody was typing continuously in the chat box. So which is very important, that make that everybody so concentrated and listening carefully. And this is the purpose of these webinars. So thank you everyone, and thank you Dr. Saurabh, Dr. Neeraj, and Radhika. Thank you everybody. Thank you, lovely.
Thank you.
Yeah, thank you very much, Dr. Radhika Appal, for the presentation, and thank you very much, Dr. Saurabh Gupta, Dr. Neeraj Agrawal, and Dr. Manish Tomar for joining. And thank you, trainees and faculty members, for joining.